Well, we are short on people, Chelsea, but I am curious now, so you have to go ahead and hopefully we'll have a few more joiners. Our didactic presenter actually is ill, so I don't think we'll have a didactic, but we will at least get to talk about this.
Okay, all right. Well, let me get back to sharing my screen. Okay, so I'm Chelsea. I'm a nurse practitioner at the East Carolina Pediatric Sickle Cell Center. And so I'm presenting a case on breast augmentation in one of my patients because she needs clearance and there's lots of peculiar things, and we're not super up on breast augmentation in pediatrics generally. All right. Can we go? Okay. So I'm presenting CW. She is an 18-year-old female with hemoglobin SC disease and pendulous breasts. They stress her out. She doesn't like the way they look, so she does want them fixed. She has looked around the world at surgeons. She was really pushing for like Japan, and I told her that would be really, really challenging. So she is planning to have that done in Tijuana, Mexico, not Mexico. Sorry, I can't type. One of the questions that I have, so you guys can be thinking on it, is with breast augmentation. So she's getting a lift, and then they can either do tissue transfer, which is like essentially liposuction one part of the body, and they put that tissue in the breast area, or a traditional implant. So she's kind of leaning toward implants at this point, I guess. But the last time I spoke with her about a month ago, she was leaning toward the tissue transfer. So they are a military family, so they'll have somewhere to stay in San Diego for a few days prior to the surgery and then several weeks after, because Tijuana is just over the border. This is a busy slide, but essentially she has really pretty good labs. Her only daily med is hydroxyurea. White count is normal. Hemoglobin is a baseline of 10. Platelets look good. Neutrophils are good. No end organ damage stuff that we're seeing. She is, like I said, on hydroxyurea, has SC and a really robust fetal hemoglobin response. So that's hopefully good. As far as the traditional echo presentation, medical surgical history things, she did have acute chest once documented in 2019, and then does have a history of iron overload, which has been treated and resolved, but otherwise no history of thrombus, AVN, renal disease, leg ulcer, stroke, hypertension, pulmonary hypertension, any issues with blood transfusions, chronic pain at this time, or any issues with addiction. And then her only relevant surgical history is a history of cholecystectomy. And then she has an infusive port as well. The abscess is when she was very young, like 6 or 7 years old. One of the big things for her is she has a very long, extensive mental health history. She struggles with anxiety, depression. She has a history of SIs, auditory and visual hallucinations. Her treatment has included residential treatment, partial hospitalization, and an intensive outpatient program. And then she also did transcranial magnetic stimulation, TMS therapy, in early 2025. It's not something I was super familiar with, but essentially it's like targeted magnetic pulses. And she got it for, I think, 38 days straight. And she's had significant improvement since that time. The family has decided to take her off of all of her psych meds. She has tried probably at least a dozen different psych meds. She does still have some auditory and visual hallucinations. She doesn't have any command hallucinations. They're more of an irritation to her and a frustration. But she keeps saying they want to do a natural approach, but their natural approach is like just nothing as far as I can tell. Like I don't, other than therapy. So I don't know that there's any supplements of any kind. They're just not doing medications. But honestly, overall, since the TMS, she's doing well better than she was. And then she's still doing virtual therapy twice a week. The other big issue with her is she has a history of compulsive skin picking back in from 2022 to 2024 with an admission for MSSA bacteremia, secondary to skin picking of the breast last summer. So she says that was, kind of like an anxiety thing that if she wanted to do self-harm, she would do that instead, although arguably a version of self-harm. But she says she's not had that issue in a long time. Already said her hemoglobin is a baseline of 10. She has SC, so we've never done TCDs on her, but she was on transfusion therapy, like chronic transfusion therapy, I guess twice in her life, for recurrent pain. Like that was a treatment that was done by our team. So 2017, 2019, she was on transfusions, and then took her iron chelator then. And then briefly between 23 and 24, we tried it again when she was having very frequent admissions for pain again that time. She did not require any chelation at that time. So in 20, sorry, I got ahead of myself. In 2024, transitioned to hydroxyurea and then has been on a stable dose of 1,500 milligrams, which is 26 mg per kg per day. She does have a port in place that was placed in 2023 when she was restarted on transfusions due to her poor IV access, and she comes in religiously monthly for her port flushes. She has not had any emergency room visits or hospitalization since 2024. She had one in January of 24, two in July of 24, and then one in December of 24, and then none since that time. So she is certainly better managed than she was a year ago. She's in a much better place than she was a year ago. You already saw a sneak peek. This is what the breast picking looked like kind of in its healing phases, but she did obviously have to be admitted. So pretty significant stuff. And like I said, back in July of 24. So I was not super familiar with breast augmentation. I know this is not a didactic, but just a really brief review of why we're concerned and what we're concerned about. So fat transfer is probably going to be a longer surgery, so more time under anesthesia, with the implants probably being a shorter surgery. Long-term maintenance-wise, sometimes they have to do regrafting, although I would imagine she would probably not go for that as long as she's getting the lift. I think that's the most important thing to her, as she's explained it, but there's no device. So there's always issues with implants potentially needing revision or replacement. Obviously a foreign body with the implants, which is not the case with fat transfer. As far as imaging, which is not something I had even really thought about before. So with the tissue transfer, we can have calcifications that can impact, I guess, depending on which imaging you're doing. And then implants can interfere with mammography and other imaging as well. And then just sickle cell specifically, there's more surgical locations with the fat transfer, since we're doing the liposuction section and the implant section. And then, you know, essentially the microvascular compromise that we're dealing with sickle cell, if we're moving tissue, are we sickling within that tissue and then we're moving it, and how does that work? So the implant, there is surgical stress, but probably less of the vascular issues than we would see in the tissue transfer. And then in by specific concern for the wound disruption, there's going to be more potential infection sites and more potential picking places with the fat transfer. And then the implants, kind of same thing though. You're going to have an incision there. And then is the reduced oxygenation going to impair anything? We're of course always risk of infection. We're always worried about risk of infection. And then scarring, I don't know that it will be significantly different. I don't know that that'll be like a decision-making point at all. And then of course, just the psychological stress of this whole thing. So the worry about what she's going to look like, the travel, the being in another country, all of that stuff is going to be a lot of stress. And we know that obviously stress can trigger a lot of sickle cell problems. And then this is the surgical clearance letter we got. So essentially they interviewed international surgeons, multiple international surgeons, and decided with this clinic in Tijuana. There are lots of plastic surgeons in Tijuana, I learned. Lots and lots of plastic surgeons in that area. They're asking for very reasonable lab work. Like I said, she's going to go down there a couple days before and then plan to stay few weeks after the surgery for that immediate post-op period. So I'm hoping for a discussion on several points. Obviously, we plan to exchange transfuse her prior to travel because her hemoglobin is 10. And we want to do a little more than nothing before she travels. To me, the implant does seem lower risk than transfer, but I'm curious if anyone has any experience. The case studies, the statistics were not robust. Like most people did okay, but a couple people didn't. But it is, single cases, or like I think I reviewed 10 cases and 8 of them went well and 2 did not. So not a lot to go on there. And then does anyone else have concerns about her mental health history and this surgery in general? And then as far as imaging, like depending on where, if we do implants where they are, they're going to block, even just for a chest x-ray, we're going to not be able to see some opacity. And depending where they are, we're going to miss lower lobes if we're screening for things like acute chest pneumonia. And then what will pain management look like when somebody's getting a surgery that we're supposed to help collaborate on, but she'll be in the post-op period in California and getting surgery in Mexico. So that's my friend. I'm hoping you guys can maybe help because there's a lot of things we can help her with, but this one was, well, Dr. Fu and I were like, let's ask our friends on the echo.
Wow, I don't envy you.
Yeah.
This seems like one huge setup for disaster. That's my first, second, and third thought. My fourth thought was I'm glad you're dealing with it and not me. So I think to start with, Dr. Klein had a couple of questions. One that Dr. Fu answered about her BMI, but why not in the US? Is my assumption is a
Cost.
cost.
Yeah, I think it's
Okay.
cost because it's, elective surgery. So
Yeah. I would be terrified to have someone voluntarily undergo this surgery. Um, I would do anything in my power to prevent it. Honestly, that's my first, second, and third thought. I get the mental issues, but I would worry a lot about, so we have trouble even in people who have, double G chests. I can't get my breast surgeons 95.5% of the time to do a surgery on them, regardless of how much pain they have, because the healing concerns are so great. Now, I always say to them the same thing I'll say to you. Well, you haven't done them with me in partnership. I've had lots of people heal well, and they say, yes, but we've had lots of people with sickle cell not heal well, and that it seems to be a huge issue in the breast specifically.
okay.
Um, I have had good and bad experiences, but all of mine have been in reduction. I haven't ever had somebody attempt to go through augmentation.
Okay.
Um, the couple of things that I would say is absolutely stop her hydroxyurea and hold it till she's fully healed because it will reduce wound healing. Um, I would have her establish care at UC San Diego before she goes to have surgery. She's got, I assume, TRICARE, so she should be able to get care wherever she is. So I would make sure you have a sickle cell center where she is. I think it's terrifying that she'd go to Mexico. I don't know anything about blood supply. What if she needs blood?
Yeah.
I
Yeah.
don't know.
I'm
So
hoping
I
that
would,
we'll transfuse her before and then, I
but what if,
mean, who knows in surgery, but like maybe after she'll go back to Cindy. Yeah.
but at least you'd get, at least if you have her seen as a well visit in San Diego, if, I don't know how long they like need to follow her afterwards before she leaves.
Yeah.
The other big risk that I've seen, and it might be worth talking to a couple of other physicians, but is I've often seen when people have issues with implants that other surgeons won't touch them. Um, and so I always worry about that. Obviously, if they're infected, that's different, but it's sort of, surgeons are funny about things. If somebody does a joint, other surgeons don't want to fix the joint that they did. And I've seen the same thing with implants.
Okay.
Um, so that's a better question for plastic surgeons. Like if she's going to come back and she's going to be living in your area for a while, you might say, hey, talk to the plastic surgeons in the area that she might need if she has problems when she comes back.
I'm thinking.
But yeah, I would definitely exchange her ahead of time. I would absolutely hold her hydroxyurea till she's totally healed. I would plan something to keep her hands off that area. Um,
Mhm.
and I'd worry about every single piece of it, but I would also get boots on the ground. Like I would get, I can introduce you to the adult provider at UC San Diego. She's
That'd be
wonderful,
perfect.
Sariko Paul.
Yeah,
Um, but I would also do anything I could to discourage it, but that's just me.
yeah, she's gonna do it.
I
I
got that
really think she's
impression.
gonna do it. We can try, but like the best I could do was to get her on this side of the globe. Um, and even then, yeah,
Dr.
okay.
Klein, did you have other
Yeah,
thoughts?
anybody else?
So with her BMI being normal, if she has
Mhm.
very large breasts that are causing X, Y, and Z, most insurances will cover the reduction. So can she get the
It's
reduction
She's
covered?
there's
she's augmentation.
But
so
she's
it's
wants
it's
a lift first, right?
so her breasts are not profoundly large.
Oh,
I don't know all the words, but they're very like tubular.
got it.
So
Okay.
it's an
So it's
aesthetic
just
issue.
appearance. It's totally aesthetic. There's no
Yeah,
pain
it's totally
associated.
aesthetic. Yeah,
Got
there's no
it.
like
Okay.
back pain. There's no, yeah, it's nothing to do
All
with
right.
their weight.
Yeah. No, I got
I
nothing
wish
then.
that would be much
Insurance won't
easier.
cover it. Yeah.
I would also probably, I mean, I understand the naturopathic urge, I guess. But do you have somebody on the psych side that could see her ahead of time? And I think of it kind of like I do gene therapy. What if you don't feel the way you think you're gonna feel after this?
We
What
did
is
talk about, I'm sorry, go ahead.
No, I would have somebody from psychology have that conversation.
Yeah, so that was one conversation I forgot to add it in here. She has spoken with her psychologist about it, and that psychologist thinks it's, a good idea if it's going to help her and is happy for her. So I guess they did not express any concerns, at least to the patient, but I haven't reached out to her directly. So I can certainly do that and say, as a mutual patient, is there anything you're concerned about? Dr. Fu, do you have any other thoughts?
Yeah, it's very interesting. I think Julie's reaction was sort of my reaction.
Yeah.
And I remember I was like, I'm trying not to put in my, I don't know, worldview of saying, is this really worth it? So that let's bring it to the team. So I'm not, this is as a pediatrician, I've never had this issue. So uh, the other thing which so she has a psychologist. She's in psychiatry. These are people who, in my opinion, are better qualified to try to dissuade her. But my concern is somebody who has this amount of mental illness. How much is, again, she's an adult, how much is this judgment that she's made? But her parents are supportive of it.
Yes.
It just, when I look back, when she had a lot of pain, which opiates could not treat, we even did transfusion, did not treat. It took a long time for us to get parents on our side to say we are not going to give the opiates. So it's not like parents are always immediately reasonable.
Yeah, I mean, you would hope, right? Parents would be like, "You're beautiful the way you are." Um, you're
So, but I
18. Why
think
do
some
you?
of these risks that Julie mentioned about healing, and because mine was you move breast tissue from one part to the other. Yes, it's sickle cell SC, but she's behaving more like someone SS. But even that, we don't have data how perfusion is when you remove tissue from one part of the body to the other. And she has pain that is sometimes not related to some structural damage. Do we develop another chronic pain site from this? And uh, 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 but she has good mental health. She has seen not just here at our institution. She has gone to other institutions for mental health, and apparently have discussed this. They are not really asking us, should we do this? They are telling us we are doing this.
It would be interesting as well to ask the surgeon if they've ever taken care of anyone with sickle cell disease. There's a decent chance they've never. Mexico, shockingly, despite the fact that we see quite a lot of sickle cell in the Caribbean and Latin America, there's very little in Mexico. I've given a couple of talks. It's surprising, and I've always been like, where is everyone? I don't have any good answers, but it is not a large population, so you may want to talk to them about that.
Yeah, I need to talk to them directly. It's just been communication kind of through the patient, which she is a good historian. You know, she asks appropriate questions. She's been asking for this clearance for a while. But my big thing was like, does he know you have sickle cell? Does he know you have a port? Does he know you live in North Carolina? Like, are they aware of all of these things? And they still are willing to do it. And she's like, yes, they know. They said they'll talk to you. It's going to be fine. I'm like,
It's a cash only. They don't care. They can't come back to them. They're going to have to sign papers that say they won't sue or do anything else. I mean, I guarantee it. That's how these places work. And so that's why I'm saying I would try to get your surgeon
dissuade them.
locally on your side ahead of time. Like, I just think understanding that they wouldn't do the surgery locally, but understanding if the patient's planning to come back to North Carolina, say, hey, this might be somebody you need to see post-op if you're having any issues, and see if they'd be willing to see them just as a favor.
Yeah, that's a great idea.
So that one I can answer for you. They're going to say no. I think if she has a complication, they cannot say no. But they are going to say we are not doing the surgery. We don't want to have anything to do with it. But we will just tell them this patient is going to do it, and just know she's going to be in our area. I guess that's all we can really get from them.
But I maybe ask them about the tissue versus implant, the fat chant. Like, they may have a, you know, because they of course have more experience, and at least if she has complications, you want what they're most comfortable with.
Yeah, that's gonna do.
Because
I'll
I
see
mean,
if
obviously,
anybody
no
has
idea.
a connection with anybody in plastics.
Do they have to get a clearance from you, or are they going to do this surgery whether you give that clearance or not?
Let me see what this actual.
Because you could
letter-
just say, we need you to see our surgeon beforehand so you know who they are, they can evaluate, they can kind of give recommendations. I mean, I would like a US surgeon to at least lay eyes on her and be like,
Yeah.
this is what I'd recommend. And if it's completely different than the TJ person, then I would be like, I'd be concerned with you having surgery there. I used to work in San Diego. Everyone goes to TJ for everything,
For
and
everything.
complications
Okay.
are out of control, and they don't
Okay.
follow the patients. So they
Oh,
end up
God.
in our labs. So, or they maybe would, but like patients don't go back because it's Mexico and they don't want to go to Mexico for like complications.
The problem.
You know? So
Yeah.
it is very much what Dr. Cantor said, a setup for disaster. So yeah.
Okay.
But
Well,
I
I
would,
appreciate that experience too.
and I think if you're assuming that you can only try to help, right? That they're going to do it no matter what. I totally agree. I would really have them see, and I would have them see the surgeon and just as if you would have it. I understand they're going to say no, but they say, would you do a surgical consultation to
Yeah.
at least see if they could help support, which, you know, understanding that the patient's going to do it regardless, and maybe support the options again for the implant versus tissue on what they'd think. As I said, my surgeons here have been difficult, but they would do that if I asked them to. And so that might be also understanding that as Dr. Fu said, they're not going to do it, but if something happens, they're going to have to see her. So might as well head off any things in the background. But yeah, other than that, I totally agree with the transfusion. I would absolutely hold her hydroxyurea until she's 100% fully healed. And I would probably decrease your picking sites as you suggested. I mean, if it were up to me, I'd say implants, but again, what do I know? Not a lot.
Yeah.
And definitely, again, especially since they're probably TRICARE and could get seen, I would have them go see somebody in San Diego, because if they have an immediate complication, you're going to want someone there who knows what's up. And maybe as Rachel said, maybe that person, Dr. Gopal is her name, but maybe she knows somebody who's done this or something crazy like it. So she may have more information, so I can connect you to her.
Perfect. That'd be great. Thank you, Dr. Cantor.
Well, you'll have to update us and let us know. I mean, that is fascinating.
Yeah.
Terrifying. Good luck. Good skills.
Thank you. Thank you.
But yeah, no, really interesting. Any other questions from anybody else? That's such an interesting question. All right. All right, well, we don't have a didactic today, so I won't make everybody hang out for no good reason. Our St. Jude speaker unfortunately got sick. So we will follow up in 2 weeks as planned, and otherwise, happy Halloween.
Hi, thank you.